Thank you so much for having me here today. It's very exciting to be in the room with so many people who are so innovative and so creative. I want to step back a moment and I want to talk some about words. I want to think about how we create the words that we use in the conversations that we have in forums such as this, and then also start thinking about flipping it around a little bit and thinking about how might these words resonate with people who aren't traditionally sitting around conferences like this, with patients and their families. So let's start with transform. It's a wonderful word. It's an action-oriented word. It's a verb. And when you think about it, it's the sort of movement of something from one state to a dramatically changed state. Now, that can be a positive experience, and what we're seeing here at Transform is definitely that. But I want you to begin thinking a little bit more about what the transformation is when someone moves from a state of wellness to a state of illness. That's a very frightening experience. It can be very full of uncertainty. And so I think for us, thinking about the absolute wonderful aspect of transforming the healthcare system seems exhilarating and exciting. The action that's associated with transforming one's body from being well to no longer being well, or to being transfigured by surgery and having your appearance transformed, can be an incredibly different experience with that word. So just to set the stage just a little bit, I want you to be thinking about that. So this session was unraveling, and I think Dr. Snyderman did a great job talking some about that perspective. I'm going to give you a couple of others. When I first was given the title for this, I thought, well, how often do I use the word unraveling? And I realized very infrequently. And typically it's when I'm sitting down knitting, and I've been making this one sweater for my poor little grandson for far too long, and it's a stitch and a yarn that's unforgiving. So I'll be going along doing pretty well and suddenly look down and see a mistake. And so I need to then start to pull the thread to unravel it, to get back down to the mistake, to try to fix it, and then move back on again. So that's pretty clear. In the context of this conference, I think a lot of what we talk about when we're thinking about unraveling, we're thinking about investigating and solving and trying to explain things, to start to take things apart enough so that we can think about what we might need to do to put it back together in a better way, transformed, as we've already talked about. But think about this last definition for the word unraveling and start thinking about patients again. I've definitely heard patients and families talk to me about their experiences with their illness as unraveling around them, their world, their life, everything seems to be unraveling. So for us, as we think about unraveling something, we're starting to think about it in a positive frame. We're saying, let's take this apart, let's rebuild something better. But for patients and families, the idea of unraveling is a frightening time. And I've often said that the one thing that seems to be holding most of our healthcare system together is not us. It's patients and families who are holding that very fragile thread that's unfraying and coming apart. And the moment it snaps, it's when their world unravels, because whatever they needed, they couldn't get. Whatever the opportunity that they felt they needed to get access to in the healthcare system wasn't there, or some other barrier kept them from getting what they needed. So again, think about these words and think about what they mean in the context of the way they're being used in different situations. So then I thought to myself, well, you know, when I'm knitting and I unravel something, I wonder when I start to go back and fix it and put it back together again, am I actually raveling? Well, I realized I never used that word before. I wasn't really sure exactly whether it existed. But I figured since we have a word with UN in front of it as a prefix, there must be a word for ravel. What I found was actually rather interesting. It means the same thing. And there was a time when ravel was the preferred word, and somewhere along the way, there was an emphasis that we learned to place on certain words by putting UN in front of it to make it more powerful or mean something more. But what I also learned was that it has a definition that's actually almost the direct opposite, to confuse or to complicate. So again, how we look at words and what the historical meanings of words are can oftentimes predict a bit about what someone's perception might be of how we're trying to talk with them. So I play with words a lot. I love the way that they sort of make me think and help me to unpack something so that I can give it a better sense of what I want to talk about. So this sentence was actually one of the things that we were told to think about in this particular session. And it's another thing that I decided I needed to unpack. I can get annoying in that way. So I started reading it and I thought, well, patient needs must be at the center. True enough, I would definitely be the first person to say that. of untangling the complexity of healthcare. So when I stepped back from that and I thought, you know what, I can totally agree that patients need to be at the center, but I'm not so sure that even if we put them at the center, is that really going to untangle the complexity of healthcare? I actually think not. I actually think if we were to say that with any real truth here, that if we did put the patient's needs at the center and we expected that to be what was going to untangle the complexity of healthcare, we're putting far too much responsibility on patients. So I think we need to rethink exactly what it is that we are trying to do when we talk about untangling the complexity of healthcare and we talk about the engagement of patients. Because they will participate with us, they will engage with us, and they will inform and teach us. But we need to give them the understanding of how what they are going to tell us and teach us can actually have an impact. But to expect that their needs being at the center is going to be the solution that we'll be able to start figuring out how to untangle the mess that we're in with healthcare is, I think, probably a very, it's certainly not going to be a solution that I'm going to address here in my talk, and I don't think it's something that will occur in the lifetimes of most of our patients. So let me step back a moment and tell you a little bit about myself. I'm a nurse. I've been a nurse for 40 years. I have spent most of my nursing career in palliative and hospice care, and most of that work in homes. I didn't like the clinical environment of hospitals and clinical settings. I didn't find it very interesting and welcoming. But the moment I crossed the thresholds into people's homes, I found myself in a world that, first of all, was not familiar to me, but very familiar to them. And second of all, was for the most part, with very few exceptions, incredibly welcoming. People welcomed me in. They knew I was coming. They had a sense of who I was going to be and why I was going to be there. Not necessarily because I was going to be helping them with their experience of being at the end of their life, because for the most part, too many times, most patients didn't know that. They found that out in their early conversations with me, because no one actually took the time to talk with them about that prior to meeting me, to talk with them about what we were going to do over the course of the next few months to manage the last part of their life. So what I have here on the screen is one of the tools that I created many years ago. It's called cartography. It was my way of sort of saying, you know what, when I work with patients, there's a whole complexity to them. There's a whole set of communities that surround them. And when I walk into their home, I've never met them before. I have a little bit of a discharge summary, possibly, but I need to sit down and start figuring out a little bit more about what's going on. Get at the patient needs, right? So early on in my career, I would oftentimes go in with my own agenda. And I'd say, okay, well, here are the things I know I need to go through with them because of their diagnosis, because of the treatments they've been on, because of other factors that I might know about them from the clinical record. But it was very, very early on that patients taught me another way. Because what I found was when I got into their home, into their familiar environment, that they wanted to tell me their story. And I needed to learn how to listen to that story in order to really appreciate these puzzle pieces, and to take these puzzle pieces with them and start to figure out who were the communities in their lives, where were the resources that they had, where were they vulnerable to not having their needs met because there was a gap in their puzzle. So I looked at this as being their picture of health, and it was the thing that we worked with together to kind of understand where were things that would be helpful for us to start supporting them. And oftentimes what we found was that intimate community, that pink piece over there, oftentimes contained where their greatest source of support was. It was their family, their friends, their minister, the people they worked with. My grandmother would say those people are the people who come in your back door. They were the people who were there for them when they needed them at different times that were outside of the clinical gaze. They might be the people who were in their book club. I had one patient one time who told me the only people he ever talked to about the experience of his son's death were the guys in his poker club. Now that's care, as redefined that we heard yesterday. But the other thing that I learned from these patients and these families was to listen. And listening is interesting because it doesn't necessarily require ears. What it does require is an ability to sit and be with someone, to pull in the information. And you can do that in a variety of ways. You can do that face-to-face. You can do that in other ways by collecting data. And I'm going to talk to you about that in a minute. But I love this because I think listen actually has pretty much the understanding that it all has to do with hearing. But the Middle English definition for listen was inner sight, mental vision, wisdom, pulling things in from all around you to understand what it was that was being told to you. And we heard a lot yesterday about community, and I want to focus just a moment on this because I'm going to introduce you to a community in a moment that I think is novel and different and something that sort of it challenges and tests our assumptions about what a community really is. So I think what we've gotten to the point with community and health in general is that, yes, it is local, but because of our ability to be global, we can now touch people, whether it's virtually or in other ways, all across the world, and still call them part of our community. So what I want to do is talk to you a little bit about patients like me, and I'm going to introduce a video here that talks about scale. We heard yesterday a lot about scale. How can we make this work? I could never take my cartography map of one person at a time, trying to figure out with them where we're going to go, and scale that up in order to be able to help many people with that same sort of idea. But with what we're going to show you now, I'm going to introduce you to 4 people: Ed, Letitia, Jackie, and Erica. And they're members of Patients Like Me in a community that is growing vibrantly all the time. And if you would run that video for me, that would be terrific.
I just remember an overwhelming fear. I was terrified.
A lot of doctors were giving very vague answers.
I really had no clue what was going on with me.
And I just didn't have anybody to talk to who knew what I was going through.
I was diagnosed with psoriasis.
I had Parkinson's disease.
Relapsing, remitting multiple sclerosis.
Refractory epilepsy.
When you find a site like Patients Like Me and you realize that you really aren't in this fight alone, it takes an awful lot of the fear away.
I was amazed at the wealth of information that I found on Patients Like Me.
The most valuable and helpful part of the site is the tools that I get to use on a daily basis to see and track my progress.
The most helpful part of Patients Like Me is the forum for me, because it's the place where the community goes to share what's going on with their lives.
It's like a whole group of friends that understand you more than anyone else.
There's a community out there waiting to help you. Somehow, somewhere on Patients Like Me is someone who is like you.
Being able to be a part of Patients Like Me and my data contributing to research is an amazing experience.
It's using information that's available and that we can provide to find a cure, and that's what we want.
I just love the chance to be able to help someone that has psoriasis like me live a little bit of a better life and not have to go through the same experiences I've had to go through.
Without Patients Like Me, I probably would have never found out about an epileptologist who was able to offer the surgery to alleviate the seizures altogether.
Patients Like Me has made a very big difference in my life as far as my medications.
Oh my gosh, since the surgery, life has been phenomenal.
Finding Patients Like Me was, quite frankly, the best thing that could ever have happened to me.
For the first time in 31 years, I have been seizure-free. I have been able to drive again, and all of that was because of the information that I gathered on the site.
We can do much better than fighting the disease as a group than we can as individuals.
People should join Patients Like Me because it is a great place to find answers to questions to resolve your health problem, whatever that may be.
On Patients Like Me, everybody understands. There's no judging. We're just like you.
You can get a lot of data, you can get companionship, you can get understanding, you get compassion.
You can talk to your family, you can talk to your friends, and they are going to empathize. But if you're talking to someone who shares your illness, they get it.
So if you can queue up my slides for the next one, that would be great. I'm gonna. Okay, sorry. My technical problem, not theirs. They get it. A community gets it. A community gets you. Figure out who you are because there's common interests and common goals. I want to show you this slide because I want to help dispel the myth that Patients Like Me is a Facebook for health. We spend a huge amount of time on our team, and we have research scientists and PhD neurobiologists and others on the team that spend a huge amount of our time thinking about what are the conditions that patients are coming to our site for, and how can we create a persona and use user design technology and principles to create a site where we can gather the data in a way that's going to be credible and useful. So patients are reporting their information, and everything that's under the data fields that you see there is computable data. So we gather that data in surveys that have been psychometrically tested and primary outcome measures that help patients measure where they happen to be at any point in time in their condition. And we gather it and we put it into reports so that they can not only see it on their own profile, but they can look at other patients' profiles as well. Now, the stakeholders in this are the patients, obviously, but also we have the opportunity to provide this data through data use agreements, through partners and collaborations, so that ultimately we have data that's going to start being fueled into a variety of different places so that we can actually take what we're learning from people, in real time, in real experiences, and enter that into our understanding of what health is like, particularly in communities that are unique and novel. So I want to shift gears a little bit. I thank you very much for the opportunity to introduce some members of our community, but I also want to start thinking a little bit more about you and me. And I want to inspire you. I want to inspire you to leave here today and leave this conference feeling like you've got the kinds of information you need to be thinking differently about how you engage with patients. So think of each of you as being a potential patient. Maybe some of you already are. And I'm going to read this aloud. I'd like you all to close your eyes. Perhaps it would be a good idea, fantastic as it sounds, to muffle every telephone, to halt every motor, to stop all activity someday, to give people, to give yourself, to give me a chance to ponder for a few minutes on what it's all about, why they are living, and what they really want. Now, this quote was written by James Truslow Adams, who died in 1949. It's so relevant today. There is so much competing for our attention that we sometimes don't stop long enough to think about what really does matter. And when we're talking about engaging with patients, I can tell you, you have to think about what matters to them, what do we need to measure from them that's going to help them get the outcomes that they would want. And I can assure you that patients are interested in thinking about ways of being able to improve their outcomes by better understanding their own experiences through data. I have one last thought I want to leave you with. The fleeting moment on this slide is that the moment this picture was taken, just a few minutes later, those drops of dew would be gone. It's a beautiful image, and it's an image I want to leave you with. And I'm also going to leave you with this beautiful haiku written by the Japanese haiku master, Isa. Reimagine. Think about the possibilities. He wrote this after his daughter had died, and it was not his first child that he had lost. He had had significant losses in his life, but yet he wrote this beautiful haiku with huge amounts of possibility embedded in it. A world of dew it is indeed, and yet. Thank you very much. Ponder all your possibilities, and always think about what really matters. Thank you.
Please sit down. Tell me a little bit about patients like me. Is there a business model? Is it funded? Is it revenue driven?
There is a business model, and the business model is that there's value in our data. There's no charge for patients. It's free to them. There's no advertising on the site, so there's no cluttering of the experience when patients enter the site. What we do is we gather the data, we aggregate their data, and we de-identify it and then make it available to interested parties, whether that might be a pharmaceutical company, the government, clinical researchers, and we do that through data use agreements where we have privacy protections and confidentiality.
Do you have to filter or, in some sense, channel, create specifications for the data that patients put in so it's not just a huge amount of anecdotal information?
Absolutely. Well, we have anecdotal information.
Which is good.
We have a wonderful forum atmosphere that you saw when Ed was talking about it that's full of conversation. And we do a lot of data mining within that to pull out the sentiments and to understand what people are talking about. But on the other side of that, we are a research-based platform. We're a registry of sorts. We have over 220,000 patients on the site with about 2,000 different conditions represented. And what we do is we create what we call persona-based design. So we go in and we develop a community by understanding what that condition is, what the trajectory normally would be. We work with outside experts and clinicians to help us best understand that. And then our design team goes to work on creating the kinds of environment that will be inviting for a patient with the surveys that we're going to be putting in front of them. We have then the psychometricians who work on the questions to determine whether is it a good question or not a good question, and we test those and deploy those frequently. So there's a research component where we're gathering very robust, valid data that can be then computed and research done on. And then we have the social, more natural language processing data that we work with and pull sentiment from to try to understand what the experiences are like.
In so much of medical research, sample populations are self-selected because they volunteer to participate in a study or they're captive in some way because of institutions. Do you find that there are self-selecting biases about the populations who come to a site like yours that you have to account for in terms of your research?
Absolutely, and we take that into account in everything that we talk about in terms of the research that we do. We skew female, as most health sites would. We have a younger population than most would be considered within certain conditions. Now, when you look at our Parkinson's disease community, it's an older population. We understand that this group of patients are more activated already. They've found patients like me and they've decided that they want to participate. So they're not necessarily representative of all patients within the United States. That said, what we are seeing is that there's an opportunity for us to put out a platform that could be amenable to anybody who wants to create a picture of their health, whether they have a chronic illness or they don't. But the one thing that's a common factor to the patients who find themselves on patients like me is that they've had an unmet need in the traditional medical environments, that they come there seeking something that they don't get otherwise. And I think we saw in the video that patients are finding ways of connecting with each other. Because keep in mind, we can talk to each other about our patients, even though we're doing that with the layer of HIPAA and privacy. But patients don't talk to each other. We don't give them the opportunity to say, Mrs. Jones, meet Mr. Smith, and get to know each other and maybe understand what your common experiences are like. So that's where the beauty of this is about. And then one last thing, I think, in terms of the way we have opportunities ahead of us, we've recently been funded by the Robert Wood Johnson Foundation. In fact, I think only the second time they funded a for-profit company. We're very proud to say that what this will do is we're creating a platform for open research exchange so that we can create very robust, psychometrically valid and credible patient-reported, patient-centered outcome measures that can be utilized by patients and clinicians within all environments. So our site will be the test bed for them. We'll be able to put them into place from external researchers to take their questionnaires and put them in, test them with patients, and then hopefully validate them much quicker than the traditional 7-year time it takes to validate instruments today. And our patients are enthusiastic and excited about being able to participate in it.
Your research language is very sophisticated, and obviously you have high ambitions on the sort of research dimension of patients like me, but I also sense that at your center, there is a real human-to-human caregiver engine sort of driving all of this. As you look at these communities that are created by various, for lack of a better word, afflictions, various conditions of one kind or another. The metaphor among the so-called normal in the world is typically we're gathered together, huddled here, fighting the disease. Have you found that, in fact, those communities actually behave more like any kind of communities, like traditional ethnicities, that they have a certain common ground and that generates an enormous amount of other sorts of camaraderie?
Absolutely. One of the things that's just so interesting is that, we have community moderators who are in the forums all the time. They don't, it's sort of a soft touch intervention when there are things that seem to be a little awry within a community. But a community has its own social norms, and the conditions that people live with somewhat set the tone for some of those social norms. So you may have patients who are having a lot of conversations around the conditions they're living with, but then there's an entire dimension to them that has nothing to do with that condition. And so those kinds of conversations are taking place as well. And I think for many people who participate on our site, it's an outlet for them to see themselves not as a person with a disease, but a person who has certain elements of their life that is influenced by a medical condition. And yet they're now in an environment where other people appreciate and understand that same thing and realize it's life. This is about life, and we're going to be experiencing and talking about that, not necessarily
And
the
even
illness.
beyond that, I sense that some of the people who come into these communities are discovering a bond, and you heard it in the video, that represents a hunger for community that they might have had virtually all their lives in the midst of all the buzzes and bells that you were telling us to shut off a moment ago.
Exactly. You know, we learned an interesting thing in our user survey from our epilepsy community, and it was that for the about a third of the respondents to that survey told us they had never met another person with epilepsy before. Now, epilepsy is a very stigmatizing condition, a very scary condition. And to have this most of your life and to realize that you've never encountered another person with that same condition, it was an amazing discovery for us. It opened our eyes to imagine that, wow, I might see 3 or 4 people with epilepsy in my work, but this one patient who has been living with this their entire life has never met somebody else with it. So yes, the community itself, I think, is a way of being able to find ways of meeting needs that are going unmet today in our traditional environments.
So don't think of sort of condition peer groups as the Parkinson's ward.
Right.
Think of them as the book club.
Exactly.
Thank you very much.
Exactly.
That's great.
Thank you. Thank you.